Hello, and it's a pleasure to talk to you today about the role of non-biomarker-based strategies for patients with BRCA-negative metastatic triple-negative breast cancer, and we're going to focus on TROP2 antibody drug conjugates. I'm Hope Rugo, a professor of medicine and director of breast oncology and clinical trials education at the University of California, San Francisco's Comprehensive Cancer Center. So we'll start by talking about a case, and as we go through this presentation, we'll use cases to jump off and talk about different topics in this exciting area. So the first case is talking about use of a TROP2 ADC in a patient with metastatic triple-negative breast cancer who had a nice response. This is a 57-year-old woman who at the age of 38, interestingly, in 2004, had a stage 2A hormone receptor positive HER2 negative breast cancer and received standard therapy with AC docetaxel, tamoxifen for 2 years. She had her ovaries out, and then she took anastrozole for 3 years. In 2017, long after she'd completed her treatment with hormone therapy, she had a recurrence in neck and axillary nodes and rib, 8-millimeter brain metastasis. There were rare cells found without clear pathology, so they couldn't really look at the receptors again, and she was treated with radiation to the nodes and bone and capecitabine for 6 months and then stopped therapy. In 2020, she presented with weakness and pain in her left arm and was found to have brachial plexus infiltration on imaging, as well as a left supraclavicular node, which was biopsyable. And that biopsy showed a triple-negative cancer consistent with a breast primary. PD-L1 testing was done, and that showed a CPS of 10, combined positive score. So she was treated with paclitaxel and pembrolizumab based on Keynote 355 from January to November of 2021. And she had an excellent response. Her symptoms improved dramatically. Since she'd had radiation before, at that time she didn't have radiation to the area, but she was able to have additional focal radiation in the subsequently. Anyway, she then had progressive disease in the brachial plexus, took capecitabine again, and was able to stay on it for a long time. And that's actually quite different from patients who start out with a basal-like triple-negative disease, where we often see that patients' response to capecitabine is very poor or not at all, and progression-free survival is less than 3 months in general. But these patients who had ER-positive disease and now triple-negative, more luminal B-like triple-negative disease can sometimes respond nicely to capecitabine like this woman did. But then she had progressive disease in the brachial plexus and had disease infiltrating her spinal canal at C6 and was treated just with focal radiation at C6. So now she's in essentially the second-line chemotherapy setting for metastatic, now triple-negative breast cancer, and she was started on sacituzumab govitecan in October of last year, 2022, and she had an excellent response. Her arm markedly improved. She had no more pain in her arm. Her bone pain resolved, and her scans looked great. Still responding systemically, in May of 2023, she was found to have extensive leptomeningeal disease, so she was treated with whole brain radiation followed by cisplatin and etoposide. During her treatment with sacituzumab, she needed just 2 doses of filgrastim. To go through this, we went through her whole chart, just to make sure we hadn't snuck some in otherwise. But she did incredibly well with the treatment, mild nausea, and had the usual antiemetics, but nothing special. And she had a long response, so basically 7 months of response to treatment, quite nice. So this just shows you some of her disease in the brain when she progressed in the lower right-hand side here, and then her disease in the brachial plexus shown on a PET scan, as well as some adenopathy in the middle of her chest and the fusion. And then once she had responded in January, all of this had resolved, and it essentially was still gone in a slightly better picture in April of 2023. So antibody drug conjugates are fascinating constructs, and they are definitely chemotherapy. It's just a novel mechanism of delivery. So you have a monoclonal antibody, and we thought for a long time that you needed to select an antigen with a high copy number on the target cell, but we don't think that's true anymore. It turns out that these antibody drug conjugates, the second to third generation class of drugs, work even when you have a pretty low copy number on the target tumor cell, maybe when it's undetectable based on our limits of detection. But one thing that's really key is that the receptor that you're targeting has to internalize the receptor and ADC conjugate when it, after the antibody binds to the receptor. So the internalization appears to be important. And also, you have to have an antibody that has minimal immunogenic response. You don't want to make a bunch of antibodies to it. The linker is a fascinating area we won't talk about much, but it has to be stable in the plasma and be able to selectively release drug in the target cell. And there actually, it was a long time developing trastuzumab emtansine, our first ADC in breast cancer. We were involved in the very early studies, and there was a lot of work going on trying to develop a linker that could be digested easily in the cancer cell, but wouldn't release drug in the circulation. And that was quite a challenge. Now, these newer generation ADCs, whether or not they have a high drug to antibody ratio or not, have better linkers. And so that may be contributing to our improved efficacy even in patients whose tumors express the target at low levels. And then, of course, a critical component is the cytotoxic drug. You need something that's highly potent at very low quantities. It doesn't have to be subnanomolar, but that's what we generally say. But it has to be a drug you wouldn't give systemically as a naked drug because it's too toxic, because you're delivering a fair bit of drug with the antibody, but a lot less than if you give it as a naked drug systemically. It's nice if the drug is not too hydrophobic so that it can leak out of the cancer cell regardless of whether the cell is dead or not. And that creates the so-called bystander effect that I show you here, and this is, we find drug around tumor, so it's not totally hypothesis, but the reason why these new ADCs are working well is at least thought partly to be due to the bystander effect, where you kill neighboring cells that don't express the target very well. Tumor cells like to be next to each other, so they tend to stick together well, and that helps with all of this. And you can see the various steps here. The interesting thing is there are some new ADCs in development that have a low drug to antibody ratio, not the high of the current two new drugs that are approved, sacituzumab govitecan and trastuzumab deruxtecan. They have lower drug to antibody ratios, and some of them even have a more hydrophobic toxin or payload, but they're still highly efficacious. So it's not all this leaking out of the cell effect. So now let's talk about our approved TROP2-directed ADC, first in class, sacituzumab govitecan. So the rationale behind using an ADC targeted to TROP2 really came from preclinical data showing that TROP2 was expressed on all subtypes of breast cancer. And there was some data that it was linked to a poor prognosis. This was really not based on immunohistochemistry, but messenger RNA, and we don't have current data on that. But suffice it to say that it's very highly expressed, and we've seen that in tumors collected for our studies and looking at TROP2 expression, that 95% of tumors express TROP2 that can be detected by IHC. So there's more expression by messenger RNA. The drug to antibody ratio for sacituzumab is high at 7.6 to 1, and the internalization and enzymatic cleavage is not required. For example, you can have digestion of the SN38 from the antibody that doesn't require enzymatic cleavage. So it's composed of a highly specific antibody to TROP2, a linker that's hydrolyzable, so you can have easy payload release. That seems to be a characteristic of the new ADCs. And then the toxin is also interesting. It's the metabolite of irinotecan, SN38. So you're delivering a drug that doesn't need to be further modified in order to be active. Sacituzumab is approved for metastatic triple-negative breast cancer. It has accelerated approval for metastatic urothelial cancer, and it was approved earlier in 2023 for metastatic hormone receptor-positive HER2-negative breast cancer. So the rationale for studying sacituzumab in triple-negative breast cancer, of course, came about because it was an area of unmet need. So it superseded some of the other areas that were seen where sacituzumab was efficacious in this trial, which was initially an umbrella study that had multiple arms where small numbers of patients who were heavily pretreated were enrolled. But because of this sort of surprising efficacy, I mean, we had nothing to treat triple-negative breast cancer then, no immunotherapy. The surprising efficacy, the trial was expanded, which we now see quite a lot, into a phase 2-like study, 110 patients with metastatic triple-negative breast cancer who could have received any number of lines of therapy, but at least 2. They were treated with sacituzumab govitecan, which is given at 10 milligrams per kilogram, day 1 and day 8 every 21 days, with cycles progressing until toxicity or progression. And although the eligibility required 2 prior therapies, you could have had 1 therapy if you progressed within 12 months of adjuvant therapy, which led to a more liberal approval by the FDA in the use of sacituzumab. All patients had to have prior taxane therapy and measurable disease because the primary outcome for this trial was response rate. And they used blinded independent central review in order to assess the efficacy. So this shows you the results with our now very familiar waterfall plots. It's kind of fun now to see all these waterfall plots that show such amazing responses. And you can see that the patients in gold had stable disease, which was at least 6 months. So that's already a very impressive outcome for patients with metastatic triple-negative breast cancer who have received other treatments. But there was also a really high partial response rate in some patients with complete responses overall for a little over 33%. The toxicity at that time was neutropenia with 8% febrile neutropenia, very mild nausea, vomiting, and diarrhea, 8% diarrhea, which we'll talk about a little bit more. And then about a third of the patients had complete alopecia. Now, these patients were heavily pretreated, a median of 3 lines of prior therapy with a range of 2 to 10, although I have to say it's hard to think of 10 regimens, but this was in the advanced setting. So remarkable results. And in fact, this data led to accelerated approval because the data was finally presented after the phase 3 trial, Ascent, that we'll talk about next, had completed accrual. So the FDA can do accelerated approval in that setting. You can see the response, onset, and durability in 36 patients, and the median time to onset of response was 2 months, with many patients responding in the first cycle. So that's really, I think, nice to see in patients with bad disease. And the median duration of response was a little under 8 months. So all of that data, of course, led to the Ascent phase 3 trial that randomized patients who'd had prior treatment for metastatic triple-negative breast cancer to receive sacituzumab or a menu of chemotherapy called treatment of physician choice. And that included eribulin in a little over 50% of patients, vinorelbine, gemcitabine, capecitabine. There were patients who fit my patient's case, and that's why I included her. 30% of patients were not triple negative at their initial diagnosis of cancer, whether it was early stage or metastatic, most early stage. 70% were triple negative at initial diagnosis. So this did include the patients we see in clinical practice who are triple negative regardless of what their original cancer looked like. 529 patients were enrolled, and they were continued until progression or toxicity as usual. The median number of prior regimens here was even more than in the phase 1-2 trial at 4, with a range of 2 to 17. But it's important to keep in mind that this trial actually included all of the regimens, included those given in the early stage setting. Almost 90% had visceral disease, as you would expect, and they enrolled patients who had brain metastases but had a 15% cap. About 13% were enrolled, and the primary endpoint was PFS in the patients without brain mets, because we know that in triple-negative disease, you can really see very fast progression and leptomeningeal disease in patients with brain metastases, as was the case in my patient as well. So you can see a little under 10% had BRCA mutations, which is interesting. A very small number of patients were Asian. And in fact, we're going to see this year data from 2 studies looking at sacituzumab govitecan in a 100% Asian population to really get a better idea of patients. And so far, the reported data looks very good in the Asian population. And you can see the median age is a little lower because they had triple negative disease. I told you about the triple negative at diagnosis already. And the most common prior chemotherapy, everybody had taxane, but most had anthracyclines, carbo, and capecitabine, previous PARP inhibitor, and a few. Somebody asked me recently if that made a difference, and it doesn't seem to make any impact on your response or toxicity from sacituzumab. Important to note that about 40% of patients had liver mets. This is a particularly bad outcome group of patients with triple negative disease. So progression-free survival by blinded independent central review was significantly longer in patients who received sacituzumab at 5.6 versus 1.7 months. And remember that the only other data we had in a patient population like this was the EMBRACE trial that randomized patients to receive eribulin or treatment of physician choice. And eribulin was given to more than 50% of patients in this study. Of course, we didn't separate out the triple negatives so well in the EMBRACE days. The hazard ratio is 0.41, highly statistically significant. Progression-free survival by subgroup is shown here, and it's easy to see, even though the dotted line is a little light here, that all of the subgroups that we would think about impacting outcome, all of those patients had a better progression-free survival with SASI than they did with treatment of physician choice. And interestingly, just to point out, the patients who had an initial diagnosis not of triple negative breast cancer also had a better PFS, as well as those with triple negative breast cancer. Overall survival was also significantly improved, and this is really remarkable in a disease where survival is so short, going from 6.7 to 12.1 months, hazard ratio 0.48, highly statistically significant. And one of the things that I think is nice to see here in this heavily pretreated population, if you just go up to where the curves are together here, this is the first scans. So you can see that a small number of patients progressed right away on both arms. But after that first scan, the curves separated, and they stayed widely separated over time. Overall survival, also independent of the different predefined subgroups, was better for patients who received sacituzumab, and that included patients who didn't have an initial diagnosis of triple negative disease, as well as those who did. And age also was nice to see here. I'll show you a breakdown of that in just as a moment. And the number of prior therapies didn't really matter, even if you had more than 3 prior therapies, although the hazard ratio is better in patients with 2 to 3 prior therapies, which encourages us to use the drug earlier in the course of treatment, as we do with our most effective drugs. One question that came up when we were enrolling in this study was whether prior PD-L1 or PD-1 use would make a difference. We had atezolizumab actually approved during that time, no longer approved. And you can see that those patients also had a very good PFS with hazard ratios close to 0.5. And liver metastases patients responded really well, and the hazard ratios were very good. Overall response, as you would expect, was better for patients who received sacituzumab versus treatment of physician choice, and 10% CR versus 2% for TPC is really encouraging. Clinical benefit rate 45 versus 9%, and of course the median duration of response was also longer. Now, what about age? We always worry about chemotherapy in our older patients with triple negative disease, and these may include some patients who have androgen receptor positive disease, maybe more indolent, but still needing treatment, and patients who lose ER over time. I've had a few of those patients recently, with metastatic disease, ER negative, like the patient I presented. And here you can see clearly that regardless of whether patients were under 65 or 65 or older, that they had a similar benefit and very good hazard ratios. And then looking at the various agents was a question also. People are always saying, well, vinorelbine isn't a great drug, and why do you include it? But it's in the NCCN guidelines, so we do. And here you can see that sacituzumab was better than all of the different agents. I always really like this bar graph. And then the absolute numbers for response and clinical benefit rate are shown below, and you can see how much better sacituzumab is. Now, one of the things to look at, which led to the label, the current FDA approval label and NCCN guidelines, are what the survival benefit was in patients who had a disease-free interval of less than 12 months, so they only needed 1 line of prior therapy. And here you can see the curves are also widely separated for PFS and OS, and so that was really helpful sub-analysis that expanded the use of sacituzumab on the FDA-approved label. I mentioned the patients without TNBC at initial diagnosis. I was really interested in this patient group because they have such chemotherapy-sensitive disease relative to the basal-like initial TNBCs. So the question was whether or not the standard of care chemo worked just as well. And here you can see that sacituzumab was also superior in this group, published by Joyce O'Shaughnessy last year. And then, big question came up about whether or not you needed to have TROP2 expression for the efficacy of sacituzumab. We looked at H scores that looks at the percent of that are positive as well as the intensity of staining. And there were so few patients who were in the H score less than 100, it was impossible to assess. But these curves all demonstrate that sacituzumab was better than treatment of physician choice, regardless of TROP2 expression. And then in data I won't show you, in the small number of patients with germline BRCA mutations, sacituzumab was also superior to TPC. So let's go on to a case talking about how we manage the toxicity of this drug. We have new drugs that are highly efficacious, but we want to balance in patients with a short survival. We want to balance the toxicity versus the benefit. So this patient is a 40-year-old woman with metastatic triple-negative breast cancer. In December of 2020, she presented with a right breast triple-negative breast cancer with a Ki-67 of 90% and abnormal nodes. She was treated with a Keynote 522-like regimen with paclitaxel, carbo, and pembrolizumab, followed by dose-dense AC, but the physician who was treating her discontinued the AC after 3 cycles because she had primary disease growth that was quite evident on exam and was demonstrated by imaging. She continued pembrolizumab and went on to bilateral mastectomy, and that showed 4.9 centimeters of residual disease with a high. We look at cellularity. It's really important to understand treatment effect and relates to the residual cancer burden, or RCB score, that Fraser-Simmons developed. The cellularity was 90%, but node negative. So she got radiation therapy, took capecitabine with pembrolizumab. But unfortunately, in January, she was being followed on a study for with scans and ctDNA at another institution, and they found a solitary lung nodule in January of 22, and they took it out, and it was a 1.2 centimeter triple negative breast cancer, but then they said, let's just monitor you. Unfortunately, just as she finished the capecitabine, in March of 22, she had a seizure, and a brain MRI showed multiple metastases. So she had whole brain radiation and next generation sequencing, then showed that her PD-L1 was CPS of 40, but of course her cancer was growing on pembro. And she had a PIK3CA mutation, which occurs in about 20% of patients with TNBC. So she started on sacituzumab, and I will say that this is an unusual setting because normally you would give 1 line of chemo, but she actually developed metastatic disease already on CAPE and then progressed on CAPE again. So I figured she fit into it. Insurance didn't disagree. So she had sacituzumab for more than a year. So she started in April of 22, and I am taking her off on Friday this week. She had SBRT to the left acetabulum in October because of a little pain in that area. She had gamma knife again to find brain lesions in January of 23. And then in February, she had a weird presentation with some renal lesions, these lesions in her kidney, which I've shown you in the scan on the right, in that right kidney there. And so I biopsied it, and it was tumor. So we radiated it with IMRT, and then nothing happened for 4 months. And I will say, during this time, she was traveling back to Europe where her family lives, going to parties and meetings, and having a really excellent quality of life. I mean, it's really been dramatic, so much so that she has been very hesitant to change to standard chemo. She presented with progression in lung in August, which I've shown you. It's a little bit hard to see, but there's a dominant lung lesion here in the left lung, and insisted on radiation again because it's worked so well. So she's just finishing her IMRT, and will start on gemcitabine and carboplatin. So what about her toxicities? So she had nausea. So when I started her, she still had headaches and nausea from her brain meds. And also I was her new doctor, and so she was a little distrusting. But she had a lot of fatigue and not a lot of nausea, but a lot of insomnia. So what we did was we took our pre-medications and adjusted them. So we dose reduced and eventually discontinued her dexamethasone pre-med. Sometimes I'll add drug because of the mild nausea for the first 3 days, and olanzapine is currently my favorite added drug. So we gave her olanzapine at bedtime, helps with sleep. which is great, has no addictive properties. And so we added olanzapine and all of her symptoms went away. I mean, she just was thrilled. She had a lot of neutropenia with cycle 1, and we were giving her filgrastim for 2 to 3 doses, but she hated filgrastim. It caused a lot of aching and fatigue. So I changed her to pegfilgrastim, and an approach I now use for all of my patients. Just give a single dose on day 9, or you can give the device with the injection that occurs by itself one day afterwards. And she, using that now, had no symptoms at all, no neutropenia. I mean, zero, just has been great. She only gets diarrhea when she travels to Europe and changes her eating habits. So what we started was giving her prophylactic loperamide whenever she travels, and that also helped a lot. And she has complete alopecia. So if we talk a little bit about the toxicities from ASCENT, you can see here that grade 3 for neutropenia occurred in well over 50% of patients, but that was the most common cytopenia, febrile neutropenia in 6% of the grade 3-4 range. And you know, I actually haven't had a patient have febrile neutropenia since the first patient I treated when I started using this pegfilgrastim after day 8 and being a little bit more aggressive on growth factors. The other thing is that there's a 9 to 10% grade 3 diarrhea rate. And so it's really important if a patient's neutropenic and they're having diarrhea to give growth factor, because otherwise the bowel wall can't be a barrier and patients can get septic. So that's really important. And of course, to manage the diarrhea, we'll talk about that again in just a moment. Nausea is easy to control. It's usually short-lived. Not as so much like some of our other drugs. And alopecia listed at 46% for the phase 3 trial. I think we find most people lose more than 50% of their hair. So those are the major toxicities. And in terms of the use of growth factors were secondary prophylaxis in 29% of patients and as treatment in 30%. Really important to consider this. And you can see the any grade and grade in the bar graphs to the right. In terms of diarrhea, pre-medication also is something, and atropine use is recommended if it's not contraindicated in a patient for early diarrhea of any severity. And atropine can really help. So it is something to think about. You give it when they come in for the treatment. There were no treatment discontinuations for either diarrhea or neutropenia in ASCENT, so it clearly can be managed, but dose reductions can be a very helpful thing, and it's usually the first thing I do after making sure patients are taking antipropulsives with diarrhea. So time to onset, it's usually in the first cycle. Most of these, you can see that neutropenia, it's usually the start of cycle 2 where you're delayed, which is kind of a pain. And then in the cycle 1 for diarrhea as well. We do really recommend this prophylactic growth factor, and I recommend the pegfilgrastim approach, which I think really is nice for patients. And for the Medicare patients, if you can use the device that injects itself 24 hours afterwards, it means they don't have to come back. And of course, treatment reduces the duration. I just wanted to mention something interesting. We know that irinotecan toxicity is impacted by UGT1A1 polymorphisms. So we looked at that in both ASCENT and the hormone receptor positive trial TROPiCS-02. And UGT1A1 UGT1A1 is the polymorphism that's associated with poorer metabolism is star 28 homozygosity. It's not so common. So if you look at the blue table, you can see that patients who had UGT1A1 star 28 homozygosity represented just 13% of the patients overall in ASCENT. But those patients seem to have more grade 3 diarrhea relative to the patients who did a little bit more neutropenia, but not much to speak of. They did have more febrile neutropenia. So I think that it's a good argument for using growth factors prophylactically in patients who get neutropenia, and then to dose reduce if patients have grade 3 diarrhea because they may have poor metabolism. We don't recommend testing for UGT1A1 polymorphisms, but certainly that can be done in a setting where you normally test for all drugs. But I think that works pretty well, the dose reduction and then use of atropine. Quality of life was maintained or improved in a sense, so that's really nice. It was superior to global health status, quality of life, physical functioning, fatigue, and pain, despite the diarrhea and some nausea in the first cycle when people weren't using enough antiemetics as pre-medications. I usually use a triplet antiemetic approach and then back down in patients who don't have nausea. I think it's important to talk about the other TROP2 ADCs. This is a big emerging area. Datopotamab deruxtecan is the next kid on the block. It has a lower drug to antibody ratio of just 4, interestingly. It uses deruxtecan, the same toxin used in trastuzumab deruxtecan, and it has a different humanized anti-TROP1 IgG1 monoclonal antibody. And then it has this tetrapeptide-based cleavable linker, so there are different linkers. They do believe that the drug has a bystander anti-tumor effect based on preclinical data, and the payload has a short systemic half-life. So there have been 2 trials in triple-negative disease and hormone receptor-positive disease that have shown nice efficacy in heavily pretreated patients in a phase 1 study. The efficacy seemed to be better in patients who hadn't received a prior topo-1 inhibitor, but even patients who had a reasonable response rate that was, quite durable. The interesting toxicity of this drug really doesn't make any sense to any of us, but it's stomatitis, and there can be significant grade 3 stomatitis. We're now using the steroid mouthwash. We've been giving datopotamab deruxtecan in our neoadjuvant I-SPY 2 trial across the United States, and I found that the steroid mouthwash is quite good at reducing the incidence of grade 3 stomatitis, but it doesn't completely prevent it. So we'll have to see as we get more data from the phase 3 trials. And Dato has been combined with durvalumab, both in the Begonia trial and in the data that hasn't yet been reported from the I-SPY 2 trial. This in the first line trial, they saw a remarkable response of 74%. And you can see in that spaghetti curve that the responses were very durable, although they did see a lot of grade 3 stomatitis. They weren't using the preventive steroid mouthwash. So I think that this is an encouraging combination in the future because Dato doesn't seem to cause interstitial lung disease. We could combine it with durvalumab, and that's being done in a post-neoadjuvant trial. Now shown here, the phase 3 TROPION-Breast03 trial randomizes 1,100 patients who have residual disease after neoadjuvant therapy to receive Dato with durvalumab, Dato alone, or standard of care with pembrolizumab and capecitabine, or together or alone. Depending on what you want to do, you can just do standard of care. There are also additional studies in hormone receptor positive HER2 negative disease. There is a study in the second line setting, and there's also a first line trial in hormone receptor positive disease with sacituzumab govitecan. And then TROPION-Breast02 is a first line trial in triple negative disease that's currently enrolling. There are also 2 trials with sacituzumab, both with pembro for PD-L1 positive and without for PD-L1 negative in the first line setting, and a post-neoadjuvant trial that is called ASCENTO-5 that's being run through the Cooperative Group Alliance Foundation, and the PI is Sarah Talani, looking at sacituzumab with pembrolizumab versus pembro and CAPE as the physician wishes as post-neoadjuvant therapy. So there are a lot of trials going on, but a big remaining question comes up for us about sequencing these ADCs. We have great drugs, patients progress, can we give another one? There's a very interesting study called TRADE DXD or TBCRC64 being done in our consortium that is being run out of Dana-Farber, but giving TDXD or Dato-DXD and then switching the drug and looking at relative response and PFS. And then we have out of UCSF that will also, we hope, be run through our consortium, a sequencing study with sacituzumab govitecan and trastuzumab deruxtecan used as standard of care. So we'll have a lot more information in the future. There's a new TROP2 ADC actually from a company in China. It's called MK2870 or SKB264. The data in non-small cell lung cancer in 43 patients was quite encouraging. And I showed you the response in EGFR wild type and mutant, 26 versus 60%. And there's a triple negative patient group that were treated in a phase 1 basket trial in China that had a 40% response rate with plans for trying to understand how to assess this agent as we move forward. We have a trial looking at induction with sacituzumab and then adding a checkpoint inhibitor, avelumab, that's part of our consortium. And then there are other arms looking at trying to make cold tumors hot, essentially. And this trial is currently accruing, called TBCRC47 across the United States, also called INSIGHT. And then Elevate triple-negative breast cancer is worth mentioning, and they're using sacituzumab in combination with a do not eat me signal, CD47, initially described out of Stanford. And magrolimab blocks that do not eat me signal to try and facilitate macrophage-induced phagocytosis of cancer cells. And given in chemotherapy, this may improve the ability of taxing the phagocytic signal. So I'm excited about the non-randomized second-line combination of magrolimab and sacituzumab govitecan. It's a fascinating drug. Magrolimab causes this kind of weird initial anemia that goes away in 24 hours, and that caused problems in studies with myelodysplasia. But I think this is a really interesting area of potential synergy and evaluation. So as we close, I'll just talk to you about one other case, immunotherapy for triple-negative disease. This is a patient who's 72, metastatic triple-negative breast cancer. She was diagnosed at age 65 with bilateral breast cancer. In the left breast, a multifocal grade 2 IDC, largest focus 3 centimeters, and 1 node with ITCs. The tumor was ER positive and had an oncotype of 22. In the right breast, she had a 2 millimeter grade 1 lobular cancer. She was treated with radiation, tamoxifen for 6 years. She had a CAF DVT and then changed to anastrozole in November of 2021. While taking anastrozole for about 1 year, she presented with a right chest wall axillary recurrence, this big mass, like a bump on her chest wall, and additional disease on imaging. And the tumor was ER 2%, so essentially triple negative, PR negative, and now the Ki67 is 25%. She had a PIK3CA mutation, but again, no expression of the estrogen receptor, essentially. She also had multiple lung nodules and multiple liver lesions, and the biggest liver lesion was 8.4 centimeters. So this had been growing for a little while. So she was treated with weekly paclitaxel, but because the ER was so low, she moved from Chicago to San Francisco when she got diagnosed. So I suggested that we get a CPS, a PD-L1 test, and it was greater than 10. The test they sent in Chicago gives you a result that just says greater than 10. So I changed her to nab-paclitaxel plus pembrolizumab starting at cycle 2. She's received 13 cycles. She has had a phenomenal response. I'll show you next, and I'm now just continuing her on pembrolizumab alone. Really remarkable. So here you can see I gave you the PET CT, although it's a little fuzzy, just to show you that there's absolutely no uptake in the liver. In August of this year, in June, there were essentially no liver lesions, just a few tiny ones, and then her initial scan that shows her liver almost completely replaced with tumor. It's a really remarkable response. And so I think that, based on the survival data we have with pembrolizumab and chemo, if a patient has PD-L1 positive disease, we use that combination first. PARP inhibitors can be used next or even as part of the maintenance strategy, although we don't have data on that maintenance with pembro. We know it's a safe combination. PD-L1 negative, of course, we tend to start with chemotherapy or a PARP inhibitor if a patient has a BRCA mutation and doesn't have immediately life-threatening disease. Sacituzumab is my choice of second-line therapy, but in patients who are relapsing while they're still getting capecitabine and pembro, or the day after they stop, I tend to use sacituzumab in the first-line setting. And then there are multiple other options. We have the novel ADCs. We talked about some. We have trastuzumab deruxtecan in the HER2 low. And then in patients who have a high tumor mutational burden, you can use a checkpoint inhibitor alone. Sometimes I've given that in combination with capecitabine, although that's not the approval or NCCN guidelines. And I think it's really important for us to consider a clinical trial at each decision point, because somebody was just asking me, but why should I do a trial instead of just something else? And there are quite a number of studies that have shown that patients who enter on trials live longer. And I think it's not just because they're in better shape, it's because they have more treatment options, and sometimes you get a win. So always think about those clinical trials. Thanks very much.